Good morning, Rhonda.
Good morning, Dr. Alex.
Can you hear me okay, Rhonda?
Yes, can you hear me?
Yes.
Okay.
Well, good morning, everyone. Can everyone see me and hear me? Is there a thumbs up that I can see?
Yes, we hear you, Dr. Alex.
Very good. Thank you. Great. Well, good morning, everyone, and welcome to Grand Rounds. Thank you for being here this morning virtually. Today, we're going to be talking about the Clinical Learning Environment Review, otherwise known as CLER, and how we can prepare for our site visit and the training that you're going to get alongside your clinical training. So let's talk about what CLER is. So alongside your ACGME accreditation, ACGME requires that you have what's called a CLER site visit every 18 to 24 months. Some institutions across the country have had 2 or 3 of these site visits. And basically, what ACGME and CLER are interested in is knowing that you are part of the development of the quality and patient safety initiative of your hospital. So we want to make sure that you have education alongside your clinical training environment, so that you can carry these types of experiences, knowledge, and expertise into your area of practice, wherever that might be. So what are the goals? We want to make sure that you understand the dynamics, the nomenclature, and the implementation of safety activities and quality improvement. And we want to make sure you're well prepared after graduation. So the CLER goals nationally, we want to make sure that you are addressing patient safety and reduction in healthcare disparities. We want to make certain that the sponsoring institution is engaged in promoting these six goals or focus areas, which I'm going to talk about here shortly. And we want to emphasize that the responsibility of the sponsoring institution, in this case it's OSUMC, under OSU Center for Health Sciences Consortium, that we are developing a culture of quality and patient safety. So here are the 6 focus areas, and they are patient safety. Under healthcare quality, we also have healthcare disparities. Clinical learning environment is really duty hours, fatigue management, mitigation, and well-being. We have transitions of care, which is now morphed into a concept known as teaming, and we'll talk about that here shortly. There is supervision, so we want to know how well our residents are supervised in their disciplines, and we gather information with regard to that. And of course, underlying all this is our professional relationships with our colleagues and our patients and family members. And so we're going to be talking about these individually as we move through the presentation. So our site visitors that come in from Chicago have several questions for us when they get here. Now, prior to the pandemic, these would be in-person visits to our institution. However, because we are in a pandemic right now, CLER is looking at making some virtual visits. At this point, we don't really know what that format is going to look like, but we'll have more information. So prior to the pandemic arriving, we were slated to probably have a visit, an on-site visit, later this year or next year. However, at this point, our date is really can't be predicted. But we do need to be prepared, and we've been working on this for a few years now. And so they want to know just how involved our residents are in the quality improvement patient safety efforts of the hospital. They also want to know how committed the hospital is with regard to engaging and inviting our GME department into these into their quality improvement patient safety quality improvement efforts. So let's talk about what we're doing here at OSUMC with regard to some of these areas. So the way we've kind of organized around these 6 areas is that we have committee representation. we have these 6 committees, and each of these 6 committees has a chairman. And the chairman of each of these committees also has members that are comprised of faculty members and residents. So under patient safety, our chairman is Dr. Aaron Lane. Under quality improvement, our chairman is Dr. Crystal David. For professionalism, the chairman is Dr. Christopher Thurman. Under well-being, Dr. Sarah Hall. Under supervision, it is myself, and I'm also the interim chair for teaming. So under patient safety, it's going to be really important that all of our residents and faculty, fellows, all know what the 2020 Hospital National Patient Safety Goals are. Now these, of course, are things that we do on a daily basis, but our site visitors, whether virtual or in person, are going to be asking questions about our knowledge, so our residents' knowledge. And of course, these are the National Patient Safety Goals. They don't change very much from year to year. So we identify patients correctly, how we can improve staff communication, that we use alarms safely, that we use medications safely, of course, infection prevention, identifying patient safety risks, and preventing mistakes in surgery. These are all identified by the Joint Commission. So our 10 patient safety goals, if we were to drill them down and they were to ask you, list some of those patient safety goals, they would be to use 2 forms of patient identification. All right, reducing transfusion errors related to patient misidentification, reporting critical results on a timely basis. We want to make sure that we have that information through the electronic medical record and through core texting as indicated, labeling medications, of course, reducing harm from anticoagulation therapy, hand hygiene, okay, so foaming in and out, very important when we see our patients, reducing hospital-acquired infections, and of course, reconciling medications on discharge, identifying patients at risk for suicide, and of course, preventing wrong patient, wrong site, and wrong procedure. These are all identified by Joint Commission, so please know these. And as we get closer and have a better idea as to when we're going to be, when we're going to have a site visit, we'll of course send this information out again just as a reminder. So under patient safety, how are we gathering information as it pertains to the safety of our patients? We do have a risk management tool, and every hospital has a risk management tool for incident reporting, and our tool is known as Verge. And basically what we do is the residents in each of the programs will submit a certain number of incidents. It goes into a database, and our risk management and quality department actually investigate these incidents, and then at the end of the month they are reported back to the programs so that the programs can discuss them in their didactic programs. So these are de-identified, and the information is really closing the loop so that you all get the information back from the incidents that you have reported, which we think is very important for your development in patient safety. There are monthly safety event team meetings, and we do have both faculty and residents assigned, as well as hospital staff and administration. We do have multidisciplinary mortality and morbidity conferences. However, at the present time, those are on hold because prior to the pandemic, we had them in the auditorium. We had an excess of 100 people in there. It was very interactive. So as soon as we can determine another formal way to have M&M. That's currently on hold for now until we can aggregate in a safe manner. Health streams training, you'll have health streams training with regard to patient safety. These are all regulatory, and all faculty, residents, and fellows and staff are required to go through these on an annual basis. We have team care interdisciplinary rounds. Many of you that are rotating through the various services may notice that we have PharmDs rotating with us. Sometimes we will have nurses that actually round with the teams as they round in the morning. This is an interdisciplinary experience, and we hope that we will have more disciplines around this type of team care. And also, this also morphs into the teaming phenomenon or teaming focus area, which we'll talk about shortly. And then we have clinical document improvement programs, CDI, teaming for documentation improvement. The manner in which we communicate through the chart is very important, and so the detail required so that it tells the full story also improves patient safety. So how do I enter a risk management? Some of you, of course, in the upper classes have used this tool and are very familiar and comfortable with it. For our PGY1s, I just kind of orient you all to this incident reporting tool, otherwise known as Verge. It is, if you enter Ozone, you get in with your username and password. You go under Departments, you click under Quality Management, and then Risk Management Incident Reporting. So once you're there, it will open up a screen that looks like this. And on that screen, you will see all these categories of reporting. So if there's issues with transfers or transport, or if there was, let's say there's an airway management issue or issues of behavior, perhaps there is transfusion issues that have occurred or incidents that have occurred. Perhaps your patient has developed a deep vein thrombosis or pulmonary embolus. Perhaps there's been a device failure or an equipment failure. If there are falls that occur by our patients, you know that you can enter these as an incident. And the goal here is to really try to trend these incidents so that we can strategically focus on mitigating risks so that we can minimize harm or eliminate harm and potentiate a safe environment for our patients along the dynamics of that healthcare delivery that we have the patient go through. So what is CLER interested in? When they come to see us, they're going to ask our quality improvement, patient safety departments. They're going to ask how many incidents are reported each year at OSUMC. Of those incidents, they want to know how many are documented as adverse events. So that is those events where harm has come to those patients. They also want to know how many near misses have been reported and how many unsafe conditions. And I will say that having seen some of the site reports from across the country, the majority of the academic health centers, the residents, primarily will submit adverse events, but they do want to also, CLER wants to highlight the importance of identifying near misses. So those incidents where harm could have come to the patient but didn't, and they want to document those as well. And then the number of unsafe conditions identified. They would like to know that number. They want to know the number, the percentage of all of these incidents that are reported by staff, the percentage reported by faculty, and the percentage reported by residents. And what they're looking for when they come back, in 18 to 24 months, they are looking for improvement in reporting year over year by the residents. They want to make sure that the residents are having a longitudinal experience in patient safety. So let's talk a little bit about the definition of an adverse event. And it has many different entities have a different definition. This is by the Harvard Medical Practice Study. And it's essentially defined as an injury that was caused by medical management, not the underlying disease of the patient, and that medical management prolonged the hospitalization, produced a disability at the time of discharge, or both. So adverse events can be defined as either preventable or non-preventable. And these preventable adverse events are usually defined as avoidable by any means currently available, okay? Also, these preventable adverse events are defined as care that has fallen below the standard expected of the physician in their community. So a near miss is an event that might have resulted in harm in the patient, but the problem did not reach the patient, okay? So by some kind of intervention, whether it be a healthcare provider, patient, family, or just good luck, the harm did not reach the patient. So these are called near misses, also referred to as close calls or good catches. So an unsafe condition is defined as a circumstance that increases the probability of a patient safety event. So you might have a piece of equipment that's defective. You might have an environment that's conducive to increasing the risk of an unsafe act. So these are all typically process failures. So we want to identify these as soon as we see them so that we can identify a strategy forward to make that unsafe condition a safe one with process. So quality improvement programs, so we'll move on to quality improvement as a focus area. Every year we publish a quality improvement handbook. It is revised on an annual basis, and we send it out to all residents, program directors, and faculty across the consortium. Our quality projects, any quality projects that you do, either the inpatient or outpatient quality projects, are captured as scholarly activities. So go into new innovations, which is your resident management data system, and you'll see a category of scholarly activity. Make sure that you are capturing your quality projects here in this category, because our site visitors may ask a resident to open up their new innovations and show them where they have not only their clinical scholarly activity, but their quality improvement projects. So please know that that is available, and please place your activity in new innovations. Every year in May, we have a quality improvement patient safety poster symposium. This year we held it virtually, and that symposium is open to all programs within the consortium across the state. So typically we have in excess of 20 posters. This last year we had about 15. As we were preparing, the pandemic kind of hit, and so we had less than we typically have, but the goal is to have every program across the consortium and of course across OSUMC submit a poster for our QI Patient Safety Symposium. Monthly, the hospital does put out a quality improvement newsletter. Some of you may have seen that come across your emails. Please open that up and take a look at, glance at the content. It has some really great information, and also it's another method with which we communicate with our GME community on quality improvement efforts in the hospital. And of course, through health streams, we have training in disaster preparedness, prevention of hospital-acquired infections, and cultural competency training. So when the site visitors come, or whether they visit us virtually, they will ask you if you know what the current quality improvement projects are here at OSUMC. So I want you to know where I want you to know what they are. And of course, you probably already know this, but please tag it as the hospital's quality improvement focus areas. And so they are CLOPSI, which is the central line-associated bloodstream infection reduction efforts. CAUTI is the catheter-associated urinary tract infection reduction efforts. So CABG, of course, is improving care for the patient after a CABG. Restraint, so we want to reduce the use of restraints, and of course document compliance when necessary, when we need to use these restraints. There's a state mandate, of course, in terms of how we document the use of restraints so that we can prevent injury and death by restraint. With regard to falls, of course, we want a fall reduction in our patients. We do have a fall response team, which is called to the bedside whenever a patient falls. We have a program known as SWAT, which is the Skin Wound Assessment Team. We want to reduce the incidence of pressure injuries. We want to get patients moving and mobile so that we can minimize the negative consequences of being immobile. And of course, sepsis reduction is something we continue to work on in improving care for their patients in the identification of sepsis, as well as the care of those patients identified as septic. So under supervision, that is the other focus area. On a quarterly basis, I want you all to know that your program director enters your competency to perform a procedure either with direct supervision or indirect supervision. So this is done on a quarterly basis, and our office audits these to make sure that they are up to date. And the reason why this is done is, of course, for your own feedback in terms of your progress through the program, but also our nurses need to have access to this part of your privileging, so that in the event that there is a nurse that's not familiar with your competencies around doing a procedure at the bedside, that they have the ability to go into the privilege log within New Innovation and see if indeed you do have that, that privilege to perform that without direct supervision. Now, I will say in a program as small as ours, that most of our nursing staff know our residents, know what programs they're in, what their level of training is. So I don't think this is something that is readily used here on a practical level. However, when our site visitors come to OSUMC, if they come here, or certainly if they do this virtually, they can ask any of our nurses to look up a resident and verify that they're able to access this information. So just want you to know that this is updated on a quarterly basis. And our nurses only have access to this part of New Innovations, just the privileging log. With regard to the annual resident survey, so every year our residents will fill out an ACGME annual resident survey, and there's 2 questions on there. And the questions basically ask, how well do you think you are supervised? Are you being under-supervised by your program, over-supervised, or just right? Of course, these are all de-identified, so we don't know who has responded in what way, and the information is sent to our DIO, who is Dr. Slick, and in an aggregate form, so we receive it in an aggregate form. And we use this information in the event that there is room for improvement in terms of our supervision of our residents. And then when you are graduating from the program, an exit survey is sent out, and there is one question on that asks how you feel with regard to your ability to function autonomously after you leave the program. So when you go into practice, do you feel that you are prepared? And the responses are yes, no, or somewhat. So we, of course, receive that information in the aggregate as well. It's very, very important to us to know how you feel your training went with regard to your ability to function autonomously. Our patient orientation packets at OSUMC now have information there that describes what it's like to be seen in an academic health center. So as you know, our patients come in, they have an attending physician who has a resident physician who has medical students, and then we have consultants who are also attendings, who have their residents, perhaps fellows and medical students. So it can become very confusing to the patient as to who is who the admitting physician is, who the consultants are. So we put together a patient orientation packet now in Spanish and in English, so that they are oriented as to what it is like to be cared for and the supervision that goes on with regard to their care in a hospital setting. And then lastly, we have simulation training. ACGME is very supportive of simulation training in safe environments where there is interdisciplinary engagement. So not only the programs and the residents themselves, but nursing, anesthesia, kind of that interdisciplinary approach, respiratory therapy. And so we have a beautiful simulation center over at OSU across the river. If you haven't had an opportunity to go take a tour, it is capable of handling a lot of interdisciplinary simulation training. Many of your programs have probably been over there in the last couple of years to do some simulation training. So again, this is something that's evolving, and we are hopeful for a more interdisciplinary approach to simulation training. So let's talk about the levels of supervision, and we talked about who can have access to that data. So direct supervision by ACGME is defined as a supervising physician or a senior resident being physically present with the patient. And indirect supervision with direct supervision immediately available. This is when you have indirect supervision and the attending or senior resident is within the hospital and is immediately available to provide that direct supervision. And then the indirect supervision with direct supervision available is the supervising physician or the senior resident is not physically within the hospital, but is available by telephonic or other electronic means. So those are basically the three categories. There are a few programs that have a identify, or where the program directors identify an oversight category. And so here, essentially the procedure or the encounter has already occurred, but the feedback from the resident, from the program director or the faculty comes after that care is delivered. And basically it's really identified for those residents that are in their senior latter part of their training program, where they have some more progressive authority, responsibility. This is also called Conditional Independence. And it just as a reminder that this is, oversight category is to be used to describe feedback after care is delivered. So here is the link that our nurses use to get into the new innovations, resident privilege logs. They have their own username and password, and they can find you by your name or by your residency program and scroll down to your name. So next is transitions of care. Now, I bring this up because this is really morphed into the teaming focus area. So beginning April of this year, these site visits were to evaluate each program in terms of their teaming. But I bring this up because transitions of care is still relevant with regard to our handoffs. So typically at OSUMC, we have the IPAS, we use the IPAS nomenclature in most programs. Essentially, these are computerized handoff tools. They're designed during the course of the day, and they have relevant information on what the patient is there for, whether they are stable or unstable, or if they are one of these categories of patients known as watchers. So those patients where their status may change, and the handoff tool is helpful in terms of the detail of what is transpired with that patient, what lab or diagnostic studies need to be followed up on during the night or the following day. So it is very structured, and it's a great tool for our faculty, for our residents during the handoff process from day team to night team to day team. Certainly it can be used also from transitioning a patient from the ICU to the general medical floor, or from discharge to home. In terms of faculty being engaged, there is an expectation that periodically the faculty member will observe the handoff and the process itself and give feedback during that process. This is what the faculty observation and feedback form looks like. This is for faculty, and we've sent this out to all programs. And it's basically just, this is just to let you know that there is an evaluation tool, an observation tool that's used by faculty when they come and visit. Teaming, again, this is evolved from the transitions of care focus area. And basically ACGME and CLER really want to see that there's an emphasis on promoting that interprofessional interaction around that patient. Whether it occurs during the course of the day, or it occurs during a handoff or a transfer between services, they want to see that there's more than just that particular team involved in that. They want to see that there is perhaps the PharmD, nursing, perhaps physical therapy. So they're really looking at ways where, and innovation, where ways in which we can really team effectively in the interest of patient safety and quality improvement. So duty hours, of course, all of our trainees are required to log their duty hours, and we expect 100% compliance with this. This is monitored not only by the program directors and the DIO, however, it is also monitored by our GME committee. We have faculty and resident presentations on fatigue mitigation. As you all know, in our GME wing, we have quiet call rooms for rest. We have an annual wellness faculty development symposium, our summit that we have in August. Every 6 months, our residents will take a resident wellness survey so that we can see how you are doing during the course of your program. We want to support your efforts in staying well, both physically and emotionally. As you all know, going through a residency training program, a fellowship training program is very rigorous and strenuous, and so we want to support you in every way that we can. We do have a resident gym available to you for your leisure. It's nice to take a break and go work out for 20 to 30 minutes, or it could be used in the evenings or in the mornings. And then each program does have an identified resident wellness champion. So under well-being as well, to let you all know, we do have what's called the OSUMC Crisis Response Plan. So this is a team that comes together when a resident may have an emotional issue or some sort of crisis where the resident is at risk. This team comes together to assist this resident and get them the care that they need. It's very important that you know that this plan exists and that if there is a concern with a fellow resident, please let your program director or your faculty member know, and this team can come together very quickly and support. We have 2 presentations per year on well-being topics in our Grand Round schedule. There is Catapult Health Screening, MASLAC Burnout Inventory, so we are able to assess our residents' burnout ratings. We have a wellness flip book that we put together every year and is posted on our CLER website. That CLER website is being developed at this time. We have a mentor and mentee program, so each resident should have a faculty mentor that meets with them once or twice a year and to see how they're doing in their program and offering opportunities for well-being support. Residents, and of course we have residency-specific wellness programs. So each of the programs, of course, prior to the pandemic, I think we're relatively social with one another outside of the training environment. And I think some of our programs have been, and our residents have been pretty engaging in a virtual fashion to kind of support each other during this time. We've had enhanced cafeteria options, and we've worked with hospital administration to improve the selections for you all. We appreciate any feedback that you might have on how things are going, because we once we have that information, we're able to go to administration and hopefully make an impact and improve your nutrition while you are all here. ComPsych is something that the university has invested in. It's a 24-hour, 7-day-a-week urgent and emergent access. This is something that you can access anonymously. That number is on the screen that you see there, 866-519-8354. You have community care. Our residents that are employed by the hospital have community care. The Employee Assistance Program is also available to you. You have 10 free counseling sessions. There is a local organization known as COPES, and that number is there as well. So please do not hesitate to avail yourself of these resources. They are very helpful. We all understand just how rigorous and how emotionally strenuous it can be to go through a training program. And so under professionalism, under ACGME and CLER, there's a main focus on honesty and integrity, and we want to make sure that your environment is free of mistreatment of any kind. So if there are any concerns of mistreatment, either by faculty or fellow residents or staff members, please let us know, because we want to make sure that your clinical learning environment is conducive to healthy interactions and so improves your ability to learn in a healthy environment. With regard to the ethical use in EHRs, now ACGME and CLER really frown upon the copying and pasting of notes from day to day, progress notes or blow-in phrases. They want to make sure that each person that sees the patient actually attributes their own observations and their own physical findings with regard to that patient in their own note. So please avoid copying and pasting. Of course, we all know what the professional code of conduct is and how we treat each other and our healthcare team, our patients, and their family members. And CLER is focused also on this conflict of interest declaration. Now, many of you have heard at the beginning of some presentations of the declaration of no conflict of interest. But what we've seen in the allopathic community and the osteopathic community is that on rotations that you might have, perhaps in the procedural areas or the surgical areas, there is a lot of innovation by some physicians that have a financial interest in a particular device or a particular treatment plan. And if you're rotating with these physicians, we encourage the faculty members that are engaged in this type of investment that they have a clear conflict of interest declaration at the beginning of this rotation. And so it's something that is apparent across some of the allopathic programs, the larger institutions with hundreds of proceduralists. So just be aware that that exists. And then we want to know how our patients perceive our professional care. And the hospital sends out HCAP scores, HCAP surveys to our patients that fall into a particular category and diagnosis. And they're sent out every year, and we do get an assessment in terms of how our institution rates in terms of their patients' perception of our professional care. So please be aware that that is a measurement tool, and it's also great feedback for us in terms of how we're doing with regard to our interaction with our patients and their family. So prior to the pandemic, we had a program known as Crucial Conversations. This is currently on pause right now. That is a very interactive program with regard to training our residents and medical students. We probably will start that again, hopefully in the spring or maybe when we emerge from our pandemic situation. But it's 16 hours of training, and it really works around working in a high stakes environment, recognizing our own emotional or our perceptions around care of the patient and how our behavior can be minimized as to protect that patient during that event, especially a high stakes event like a rapid response or another critical event. So, and then of course we have the Chief Resident Council. They also program around professionalism. Those residents that are having particular lapses in professionalism or trends and lack of professionalism that's identified, we do have a remediation process to assist that resident and support them in developing their professional attributes. So wrapping things up, what is the significance of CLER? Well, we hope, and it's the intent moving forward, that these are tools that the sponsoring institution and the GME community can mutually benefit from in terms of developing strategies around improving healthcare quality. And we are hopeful that the GME community, our programs, are seen as a value to the sponsoring institution or our hospital. So that's kind of the significance of CLER. I want to introduce to you Lisa Cummins, who is our CLER manager. You've probably seen some communication with her on many topics, particularly leading up to our Quality Improvement Patient Safety Symposium. And Melissa Bailey, she's our executive assistant, who's also a great support in our communications with all programs and faculty and residents. So here is the references for those of you that want to know more about CLER. The updated version of our CLER Pathways to Excellence is version 2.0, and it came out in late 2019. And there's another reference there for you as well that has a nice summary about CLER. And that is all I have for today. I'm happy to entertain any questions that you might have from our presentation. Quiet audience this morning. Well, hearing no questions, I hope you have a great day and a great week, and we'll see you at our next Grand Rounds presentation. Bye for now.